So what treatment options do we have? Well, we talk about hydroxyurea, but of course, angiotensin blockade also is important. And ACE inhibitors are the main armamentarium that we have. Now, most of the data come from diabetics. And the problem is there is not long-term placebo-controlled studies that are there. This is more very small number of patients. And the first one was by Falk in 1992, where enalapril was given and it reduced proteinuria. The group from Brazil actually studied a very small number of patients and showed that there was a decrease in enalapril in terms of the proteinuria. And another group from Guadalupe showed that captopril actually decreased albuminuria compared to placebo. Other treatment options are angiotensin receptor blockers when the ACE inhibitor fail, or this is a matter of choice by the doctor. And, but it needs more investigation in clinical trials. For patients with CKD, we certainly want to avoid NSAIDs. If we use hydroxyurea, we have to be very prudent. The doses of hydroxyurea have to be much lower. Recommendation is about 7.5 milligrams per kilo just to begin, and if the patient tolerates, to go up to 15. So much lower doses that we actually use in clinical practice. Erythropoietin has a role also, but we don't want to go much beyond 10 grams of hemoglobin because that increases hyperviscosity, and certainly renal replacement with dialysis or transplant. There are two current studies that are ongoing, one in the US and one in France. And the one in the US is a phase 2 of losartan. This is a children study. This is a pilot. I think they want to enroll maybe 34 patients just to get some preliminary data. And the study is with 0.7 milligrams per kilo for young children and 50 milligrams for adolescents. And the one in France is a randomized, open-label study looking at an ACE versus an ARB. And this is in adults. Kidney transplant is certainly important in end-stage renal disease, and the recommendation is pre-transplant transfusion or exchange to minimize hemoglobin S. And actually, the recommendation is to give regular transfusion post-transplant to prevent recurrence of nephropathy. Now, if you look at the effect or the survival rate between transplantation and dialysis certainly is very favorable with transplantation, 67% survival at 7 years versus 14% for dialysis. So basically everybody who has end-stage renal disease should be referred for transplantation. The main problem with kidney transplantation is organ rejection and disease recurrence of sickle cell nephropathy. There are two studies here that look at survival and graft survival as well. And the graft survival at 12 months was 89%, 24 months and 71%, 10-year survival post-transplant over 50%. Now, the problem is that the sickle cell patients are less likely to be referred for transplant. And even if you are referred for transplant, not everybody gets a transplant. So there is something that is under investigation right now. This is a corporation called Implantable Artificial Kidney Corporation. They are looking at this type of filter, and they are going to conduct a study. The idea is to be an implantable device or extracorporeal device, and the plan is for this device to last 10 years. It is in laboratory study right now. First is tested in animals prior to human trials, expected in 2017. So it's something very good if it proves to work. So where do we go from here? Well, I think prevention, again, is very important. I think the follow-up of baby hawk cohort is right now ongoing, and it will prove whether long-term use of hydroxyurea will be protective against the kidney. I actually going to looking at the prevalence of enuresis and albuminuria in these children who are older now. I think the screening of patients is very, very important with renal function tests, including cystatin C, urine albumin, protein creatinine in children 10 years and above. And I think we have to better define the risk factors for sickle cell nephropathy, since not everybody will progress, and maybe try to do more early diagnosis. And certainly large longitudinal studies are important in order to investigate treatment strategies in nephropathy. Thank you very much.
Nosso muito obrigado, doutora Álvares. E a convidamos para permanecer à mesa para compor a nossa primeira mesa de debate, juntamente com a doutora Patrícia Santos Rezende Cardoso.
Queria agradecer a brilhante exposição da doutora Ofélia Varias e vamos dar início agora ao debate, às perguntas e discussões sobre esse importante tema da nephropatia e doença falciforme. Então, está aberto as perguntas.
So, Dr. Roberts, I was curious about your data on HS syndrome and the risk of diabetes. So you mentioned hypoxia. So do you think it's sustained hypoxia associated with episodes of sickle cell HS syndrome and hypoxia, or this is episodic hypoxia that is driving
I think it could be both. Certainly there is data that the patients who had acute chest syndrome, and you have always hypoxia at that time, they can have markers of acute kidney injury. And also there is some interesting data for enuresis, which obviously is not kidney failure, but patients who has a chronic hypoxia during sleep, they have high incidence of enuresis, and they have high incidence of priapism. So you're having hypoxia during sleep, but also large tonsils. And so there is some correlation there. We don't see a lot of kidney problems in children. Of course, this is more in adults, in terms of renal failure. But I think it's both. And when I see a child, one of the questions that I always ask the mother is whether they're having bedwetting, whether they're having snoring, whether they're having sleep apnea. Because all of these have to do with many things, not only the kidney, but also learning. And so it's so important to be screened for sleep problems.
Thank you.
Eu gostaria de saber da doutora Álvares se ela tem a saturometria basal dos pacientes em que foram conduzidos tanto o Baby Hug quanto, porque eu não me lembro de ler o trial, se tinha essa saturometria e se havia alguma relação, se ela conseguiu ver isso.
I did not get the information at all.
Oxygen saturation, perfect hemoglobin saturation. Do you have of your patient
yes, we screen all the children with oxygen saturation when they come to the sports office. And we consider normal oxygen saturation 95% and above. Yeah. There's most of the patients who have low oxygen saturation to each other, but there is an occasional patient who will have lower than that.
Ofélia, obrigado pela sua apresentação. Considerando o grupo de pacientes, crianças que não usam a hidroxiureia ainda, começam a apresentar microalbuminúria, para você a primeira indicação seria entrar com a hidroxiureia ou enalapril?
I think that there is not a reason for it about that. I think it's very important to get more information. What I usually do, first of all, I need to read. So there is a percentage of patients who have intermittent albuminuria. So the first thing I want to do is repeat an ultrasound and see whether it is true. And that's stage number one. If the patient has a persistent albuminuria, and I would say my clinical practice is 100 and higher. So I usually don't start them very low, but if it is 100 and higher, I work home to start them. And I think the first thing that I would do is I would refer them to the nephrologist, and I would usually start them with an ACE inhibitor. And I will talk to the family and discuss hydroxyurea. Not everybody that I discuss hydroxyurea would be in favor of starting because it requires frequent monitoring, and I usually monitor them once a month. So if I get a denial, I think it's more based on the increased monitoring, and this is not so much that is required for ACE inhibitors. So I would say that I would have probably more leaning towards starting our ACE inhibitors and hydroxyurea, but many of them have a combination of drugs, because I think it's so important to prevent further damage, and if there is some benefit of increasing the fetal hemoglobin, I think we should do that. And also, it will not only improve them, but also will cut down the risks, acute chest syndrome and pain and all that. So I think a combined approach probably is important, but it requires further study.
Como nós não temos a cistatina C na rotina dos serviços, nós temos usado, e a dificuldade do clearance de adenina na urina de 24 horas. É sempre uma dificuldade esse exame, de uma maneira geral. O uso dessas fórmulas para o cálculo da creatinina, sendo feito de uma maneira regular, ele prevê ou antever também essa piora em relação ao exame mais fidedigno, que é o clearance de inulina ou
Actually, one of the formulas that I like to use the most is the bedside Schwartz, because it's very simple. Okay? And this is based more on the creatinine. It's 0.41 times 5 milliliters over the serum creatinine. It's a very simple formula. And in the study from Baby Hug, that also correlated quite well. But the best is the C-KIT, and actually that includes BUN, includes statins, and includes creatinine. But it's a much complicated formula, has a lot of exponents and a lot of multiplications, and of course if you have a program, you can derive. But there was a study that was published, I think, last year. This is with patients with chronic kidney disease, and not necessarily sickle cell, but chronic kidney disease. And they correlated inulin to formulas. And the C-KIT Schwartz was the best. was the best one correlated. So I think cystatin C does have a role, but if you don't have cystatin C, then use creatinine, and then think about the 0.7 and the 1 that I mentioned, and then use the bedside charts. And importantly would be what's going to happen, not only a single point, but the evolution of the patients and also how they're progressing or getting better with the adjuvant.
Você tem algum paciente usando hidroxiureia com a eritropoetina?
I did in the past. I not treated that patient. That patient was one of the ones in the cohort that I mentioned to you that was a 10% worsening of function. Very interesting was two of the siblings. They were in the cohort. Those were the ones who progressed. So I strongly believe there was a genetic component there. I didn't do genetic markers on them, but they did. The female passed away already with arrhythmias, and she went into renal failure and had a cardiac arrest as well. The male who progressed is on dialysis. I don't follow him because he's an adult right now, but he had very low hemoglobin. Actually, his hemoglobin was 5. And so I did not confuse him. I used erythropoietin in combination with hydroxyurea. Unfortunately, those two patients were very non-compliant. And it was very difficult to follow them, and I basically had to be begging for them to come. But it proved that the hemolysis could be very important. Actually, his LDH was 4,000 in this particular patient, so I strongly believe that the hemolytic anemia did play a role. And we did a biopsy on this patient, and he was full of iron. His kidneys were full of iron. So this patient did not have pain, was not this type of vaso-occlusive pain, but it was a hemolytic phenotype, and he did prove it.
Hi, Dr. Ophelia. Thank you for your nice presentation. My first question is, what we should do with children less than 10 years old? What kind of screening you recommend?
I generally do not screen them because it's so unlikely. However, if I see that the hemoglobin is very low, the patients who have hemoglobin of 6, 6.5, certainly less than 7, if the LDH is increased, if the patient has had acute chest syndrome, I will screen. So anything that I think are risk factors, but generally speaking, I would not screen them. Yeah.
Another question is about endomedicine. Since the patients have a difficulty to concentrate urine, normally to use endomedicine is of some help, as for instance in Barr disease, that we treat patients with endomedicine. But on the other hand, it can damage the kidney. What's the balance between these both tendencies with endomedicine use?
Well, I asked my nephrologist about the use of NSAIDs with CKD, and he told me no, he doesn't like it. And I worry, let me tell you, when the patients come into the hospital in pain, our emergency room uses a combination of ketorolac and morphine, and I don't like that because we are using ketorolac quite a bit, and I think from the anti-inflammatory standpoint it's very good, but it can damage the kidney. I mean, the more that we use it, I mean, we have the 5-day cutoff, mainly because of preventing GI bleeding, but it's of worry to them. So I think that if they have to use NSAID, they say they have APN, they have chronic pain, and that's the best drug. I think we need to monitor them more frequently.
Okay, and my last question, do you have any experience with double renin-angiotensin system blockade with ACE inhibitors and also angiotensin receptor antagonists in combination, combined therapy with both agents for sickle cell nephropathy?
I don't have experience, however, it is used, and my nephrologists do use it. And basically, I understand that if you use the ACE inhibitor for a while, the patient can be resistant because the aldosterone can increase, and so they escape the effect. And so it has been used, and there have been a number of papers combining use with good. However, there's some controversial, and I have also seen that some papers say that it really doesn't help very much. So I think it's a matter of study. It's something that would be important. You see the studies here that I mentioned are one or the other, and not in combination. So I think the first thing would be to prove whether one is superior to the other, and then the next step would be to use combination drugs.
Então, como nefrologista, você também contraindica a morfina, no caso de um paciente com albuminúria, e é uma quantidade muito grande de paciente com albuminúria.
No, I don't think it's contraindicated. I think you need to treat pain. I think that's the most important thing. The question is how you should use it. And I think that we need to be aware of it and maybe use bolus rather than continuous infusion to limit the amount. And you have to think maybe the clearance is lower. So you have to monitor the patients quite well. But not the albuminuria. I think those who have decrease in GFR are the ones that you have to worry the most. So in my clinical practice, if they have albuminuria, I don't limit the morphine. I just treat as they, if they make. But of course, I would be more prone to use hydroxyurea for prevention because I want them not to be in pain.
Nós temos 10 minutos. Queria fazer uma pergunta também do Prefeito. Então, o ponto de corte então, da albuminúria seria acima de 30 mg por grama de creatinina ou valores mais baixos? E o screening, nós começaríamos com pacientes na infância, após os 10 anos, que nós já sabemos que as alterações começam nessa época, ou seria mais uma idade precoce para fazermos o screening das nossas crianças com doença falciforme? Então, ponto de corte acima de 30 ou 20, e qual a idade que nós deveríamos começar já a fazer o screening de nossas crianças? Já sabemos que é a partir dos 10 anos que começam as alterações, mas deveríamos começar numa idade mais precoce?
The cutoff has been done both at 20 and 30. And their papers are using the cutoff of 20. But the one that is the best, the one that has more followers, is 30. So I think 30 should be the cutoff. In terms of the beginning of screening, I think it depends on the population. I think you have more of the CAR phenotype here. That is a matter of controversy because one side, Power says yes, about 80% of the patients with the CAR haplotypes in adults are in renal failure. On the other hand, we have other people saying no. And I think people in Brazil look at patients with a CAR haplotype or non-CAR haplotype and actually do no difference. But I think I think that if there is consideration of that, and if you can do it, I think screening earlier would be the best. Certainly, in the cohort that we have with Baby Hug, we are screening more at 10. But I think you have to individualize, as the main thing is prevention. I think the earliest you screen, the best. I mean, we know for TCD, you're screening at age 2. So I think it deserves more investigation, but you wouldn't harm. I mean, it's so simple to screen. So simple. I mean, to get your test and screen, either with a urine dipstick or with the best, which I think is the argument to creatinine ratio, I will go for it, you know?
Minha última pergunta, em relação à pressão arterial, nós que acompanhamos adultos, nós hoje damos mais importância à hipertensão do que antes. Nós um pouco negligenciávamos a questão da pressão na doença falciforme. E você tem, qual o critério que você usa? Porque 14/9 para ele já é hipertensão. E a partir de que momento você entraria com alguma medida preventiva? E desses casos, óbvio que a gente está lidando mais com adulto, e essa frequência é maior, né? E nós temos, além disso, a expectativa de vida aqui também no Brasil, sabe que está aumentando, e nós temos vários pacientes com doença renal crônica avançada ainda, alguns em diálise, vários não, em uso de hidroxureia, eritropoetina. Mas essa questão da pressão, a gente fica ainda sem muita consistência de dados para entender até que ponto a gente pode esperar, até que ponto agir para prevenir uma piora no caso da doença renal.
Well, this was a draft from this U.S. expert panel, and I think they were very conservative with that. There is a reference by Belo, published about 2 years ago, in 1998, where they studied the blood pressure norms for children with sickle cell, and certainly we know that it's lower. So I will look at the 90th percentile for age, looking at that table specifically at the paper, and I believe that the mean is about 110/60. So it's a very low blood pressure, even for adults. So anything above 120 and anything above 80 is high. So I think that would be a point of start to treat. And the other thing is that the hypertension is associated with higher mortality and higher incidence of stroke. So not only the kidney, but also the brain and the life.
Eu gostaria de perguntar sobre o uso da eritropoetina e as baixas respostas desses pacientes com eritropoetina. Se você tiver alguma coisa, uma maneira que ajuda a melhorar.
I think you were asking about the use of erythropoietin. I usually don't use erythropoietin. I think the data for erythropoietin is not a lot, but it's certainly used for patients with end-stage renal disease, and it's used 3 times a week. I believe that a big use per kilo. With dialysis, for instance, but you have to be very careful. You don't want to increase a hemoglobin over 11. And so, because it can increase viscosity, it can increase thrombosis. So you have to be very careful. But it's only in the subset of patients with advanced kidney disease, not the regular. And I think the data for the combination of hydroxyurea with erythropoietin in sickle cell is not there. I mean, it's not the real benefit of that. I think hydroxyurea alone is enough. Or you have the alternative if the patient has very low hemoglobin and you want to help them, also to put in chronic transfusion. I mean, that's another alternative you have. If you do, then I wouldn't advise the use of the ferrocerox because it can cause kidney impairment. So I would use the ferroxamine when they need to have iron chelation.
Mais uma pergunta. Vou fazer uma pergunta então, doutora Ofélia. A respeito, nós temos muitos pacientes adultos, jovens, que já apresentam albuminúria, né? Então, como a hidroxiureia seria um papel protetor no clínico, em fase precoce da doença renal renal desses pacientes? E será que não estaria indicado usar a hidroxiureia precocemente, mesmo em pacientes assintomáticos, sem crise vasoclusiva, outros indicadores de indicação da hidroxiureia?
You can see that the baby heart data failed to show a difference in the GFR by BTPA. However, it did show some improvement in the volume of the kidney and in the urinary concentration. The physicians, the investigators for the baby heart, actually are very leaning toward